And in 1989, from the first time in Belgium, we switched from the use of krypton to do a ventilation study for lung scanning to Technigas. And it was a marvel. And the reason is because, as you know, for krypton, you have to have an on-site generator. It's a very short half-life, so the convenience is definitely not there. Always limitation in any technology that you use. But let me put it this way. I think practitioners have come to realize that unless you have the best possible tool to make a diagnosis, you should not use a suboptimal tool. So it's very difficult to read ventilation scintigraphic studies done with aerosol, technetium DTPA, technetium MDP, and so on. Very difficult to read along scintigraphy. Some centers are still using xenon 133. Very difficult to be formal in terms of diagnosing pulmonary embolism. The probability that you will have a non-diagnostic study with Technigas is really small. So you don't necessarily have to you don't necessarily need to have a pulmonary CT angiography to confirm or to validate or to not confirm a suspicion of pulmonary embolism on the VQ scan. So it makes a difference in terms of the ability to make diagnosis of pulmonary embolism, but also it makes a big difference in terms of patient management. You make the diagnosis, you treat. If you don't, the mortality of the patients, if you miss the diagnosis, is quite high. So you want a very possible best tool, not only in terms of technology, but also in terms of radiopharmaceutical. So the current standards in terms of VQ scan in nuclear medicine is basically macroaggregate of albumin labeled with technetium 99M, a SPECT, if not SPECT CT images of the lung, and on the ventilation side is most definitely Technigas. Technigas is particle of carbon labeled with technetium, very fine particles. So basically you have very few limitations, particularly in patients with COPD. You still have a very nice, very uniform distribution of the tracer in the lungs of patients. So you can basically make an accurate diagnosis. The standard of care at this point in time should be MAA of microaggregate of albumin labeled with technetium for perfusion. And in terms of ventilation, it should be Technigas, which are carbon particle labeled with technetium. So I wish Technigas would have been in the United States when I moved to the United States in 1993. I'm keeping my hope high that by the end of this decade, Technigas will be approved. The sooner, the better. One thing that we should put the emphasis on is, unlike CT pulmonary angiography, VQ scan gives you not only the ability to make diagnosis of pulmonary embolism, but also enables you to describe the function of the lung, both at the level of the airways and both at the level of the vessels. CT cannot give you that. It'll give you anatomy, but it's not going to give you function. So the next frontier in terms of VQ scan, in my mind, is basically a better ability to quantify the many functional aspect of the lungs.